mentioned, aspirin is become more interesting nowadays because we have the data that recently presented this year for the benefit of aspirin in early stage colorectal cancer. So before that, the rational use of aspirin in the colorectal cancer is based on multiple mechanisms. Firstly, aspirin has an anti-inflammatory effect which can inhibit COX. COX overexpression can be presented all kinds of cancer, and it can induce the tumor inflammations and resulting in the tumor cell proliferations. And secondly, aspirin have anti-antiplatelet activities. Aspirin can prevent the platelet aggregations and prevent the tumor cell that combine with the platelet and become a microemboli, resulting in reduce the risk of the distant metastasis. And thirdly, aspirin have the immune moderation effect that can enhance immune response against the tumor cell by activation of CD4 and CD8. And lastly, aspirin may inhibit the DNA damage by actually inflammation can cause oxygen-free radicals and can produce DNA damage. So aspirin inhibit the inflammation and can reduce that. This is all the reason why aspirin become one of the most interesting drugs that have been evaluated in the cancer treatment, including colorectal cancer. So this is a summary of the aspirin in the colorectal cancer. Previously, we have the data that aspirin can reduce the risk of colorectal adenoma from multiple randomized studies. Aspirin also reduced the colorectal cancer recurrence and also reduced the mortalities in the multiple observational study as well. And we have the data from the retrospective study that PIK-TCA might predict the response of the aspirin. Not all the patients will be respond to the aspirin. So earlier in the study for the adjuvant aspirin, we have the data from the ASCO trial. As you can see, this study was conducted since 2007. It's nearly 20 years ago. ASCO trial is a multi-center randomized study that evaluate the patients who are at the age over 18 in DUC or high-risk DUC colon cancer. They still use the DUC terminology. They also include the patients who have DUC and DUC rectal cancer who completely treated with a surgery and receive adjuvant chemotherapy for at least 3 months. In this study, the patients who are not eligible for aspirin or the patients who have the family history of the colon cancer were excluded. And they randomly assigned to receive the aspirin at the dose of 200 milligrams for 3 years compared with the placebo for 3 years. And they follow up the patients up to 5 years. The primary endpoint of the study is the progression-free survival. And here is the result. Adjuvant aspirin did not meet the primary endpoint. So they cannot demonstrate improvement in the disease-free survival or overall survival in unselected populations. However, even if this is a negative study, but this study also demonstrates that aspirin is safe enough to use as a 3 years durations. And they have only minor GI bleeding for 3 cases in the aspirin arms compared with 1 cases in the placebo arms. So what about the PIK-TCA? So that study is negative. So this is not the standard of care at that time. What about PIK-TCA and colon cancer? If you see here this graph, you have to know that the PIK-TCA mutation is common in colon cancer. And it's commonly found in the exon 9 and exon 20. The incidence of the PIK-TCA mutation in colon cancer was found around 10 to 20%. So when PIK-TCA mutations occur, it can activate the PIK-TCA AKT-mTOR pathway. And this pathway can crosstalk to another cancer signaling pathway, including MAP kinase pathway, ERK, NF-kappa B, Wnt, or Notch. All of these pathways together is promote cancer cell proliferations, promote angiogenesis, and promote cell metastasis. What about what about PIK3CA mutation in Thailand? Actually, we have the data from our group that PIK3CA here that show in the red color. We include the patients for early stage rectal cancer for around 100 cases, and we found the PIK3CA mutation rate around 12%, which is in line with the global populations. Back to the aspirin and PIK3CA pathway. I mentioned that when you have the PIK3CA mutation, it will downstream activating pathway for this part. If you use the aspirin can inhibit multiple sites of this pathway. Aspirin also inhibits the COX overexpression as well. So all of this together is more than enough hypothesis to use aspirin in the colorectal cancer treatment. And Alaska trial did it. They designed a study that examined the aspirin effect on the disease recurrence by using PIK3CA gene mutation as a predictive biomarker for select the patients who might benefit. And here is the Alaska schema. This is quite complex, and I will explain one by one. In this trial, they include the patient with stage 1 to 3 rectal cancer or stage 2 or 3 colon cancer. They have 3,500 patients, including in the clinical trial. And they found 37% of the patients in this group carry PIK3CA mutations, which means the prevalence of these genes was found 37%. And if you drop down in 20%, you're gonna see that the PIK3CA mutation in the exon 9 and exon 20, which is the most common mutation in these genes, was found around half. And half of them are PIK3CA mutation other than hotspot, that hotspot exon 9 and 20, but the same pathway of PIK3CA mutations. And they divided this group of patients into two groups, which is group A and group B. And these two groups, they randomly assigned to receive the aspirin at the dose of 160 milligrams a day for 3 years compared with the placebo. And the primary endpoint was time to colorectal cancer recurrence at group A. And the secondary endpoint is of time to colorectal cancer recurrence and disease-free survival in group A and group B. And here is the baseline characteristics. They include the 626 patients in the study. And the median age was 66 years old, and around half of them were females. 2/3 of the patients have colon cancer. If we drop down the colon cancer and rectal cancer to G&M staging, you're gonna see around half of the patients have the stage 2 colon cancer and half have the stage 3. For rectal cancer, 40% of the patients have a stage 2 and stage 3, while 20% have stage 1. In the rectal cancer, around 50% of the patients receive neoadjuvant treatment. And around half of the patients in colon cancer receive adjuvant chemotherapies. And this is the result. In this group A, which is a primary endpoint, adjuvant aspirin for 3 years reduced the colon cancer recurrence for 50% with a hazard ratio of 0.49. The 3 year local recurrence, the 3 years local recurrence was 7% in the aspirin group compared with the 14% in the placebo group, which is the met primary endpoint. We also have the group B, right? The group B of the mutations, even better. If you can see here, the risk of the lower risk of the recurrence was only around 40% with a hazard ratio of 0.4, which means if you have the PIK3CA mutation in the hotspot mutation or the other hotspot mutation, but located in the PIK3CA pathway, you will benefit for adjuvant aspirin for 3 years. Moving into the secondary endpoint, which is disease-free survival. So if you see the number, you're gonna see that adding aspirin can numerically improvement in the disease-free, 3-year disease-free survival, even if it's not statistical significant from the group A, but it's with statistical significant in the group B. However, when we combine all of the group together, it's less statistical significantly. Moving to the subgroup analysis, Alaska Thai did not have the power to detect the subgroup. However, if you see for the forest plot here, you're gonna see aspirin is a robust strategy and show the benefit across the subgroup, including the patients who have either hotspot mutation or not, or receive or not receive neoadjuvant or adjuvant therapies, or either stage of colorectal cancer. And interestingly, the women have a stronger benefit when compared with men. We should, so we should. But not we have to be colon, no, we shouldn't. Moving into the safety profile, as everyone knows, aspirin have more adverse events when compared with the placebo, including the severe adverse event. However, the severe side effect is very rare, and this is the known side effect for the aspirin when we use rather than the colorectal cancer. If you're focusing on the common SAE, this is you can see the post-operative complications or DVT or embolism more than the placebo arm. But the side effect that we concern is the hemorrhage. You're going to see just only 4 patients develop the SAE for the hemorrhage, which is very small number. So all 4 of this study, which presented in ASCO GI this year, NCCN guideline incorporate quick TCA testing as a part of the standard of care to identify the patients who might respond to the aspirin. And aspirin at the dose of 160 become a part of adjuvant care. This is the new data. However, I think not only aspirin is not enough for these years. If everyone can remember for the adjuvant treatment colon cancer, we know that chemotherapy is standard of care, especially for the stage 2 colon cancer and every case in stage 3 colon cancer. If you go back to the study, we have mosaic study. If anyone can remember, we add the oxaliplatin to 5FU and demonstrate overall survival benefit over 5FU alone. And in that one, the mosaic launched since 2004. I repeat it, 2004. And after 20 years after that, we have no new data from the adjuvant treatment for the colon cancer. But these years, we have aspirin, right? In stage 2-3 PIK3CA mutations, but not just only aspirin. Earlier, 1 month earlier, in the ASCO meeting, we have the data from the atomic study, which used atezolizumab for 1 year. This is a immune checkpoint inhibitors, which is an anti-PD-L1, combined with FOLFOX regimen for 6 months, compared with standard FOLFOX 6 months, which is the standard of care for stage 3 colon cancer, right? But if the patients have deficient MMR tumor and we randomly assign to receive these 2, adding immune checkpoint inhibitor can improve in the 3 years disease-free survival and reduce the risk of recurrence around 50%. And this is a practice-changing adjuvant treatment for stage 3 colon cancer. Moreover, New England Journal of Medicine next month just published the data from the structural exercise after adjuvant chemotherapy for colorectal cancer. They randomly assigned the colon cancer who received complete adjuvant treatment and received structural exercise for 3 years. So they have the detail of structural exercise, which is not normal exercise, compared with just only health educational material. Like we told the patient, you should do more exercise, you should do more exercise. And after this data published, structural exercise can improve disease-free survival with a hazard ratio of 0.72, which met the primary endpoint. And also improvement of 8-year overall survival with a hazard ratio of 0.63. So can be done in all of colorectal cancer patients. So in the summary, I think this year we have paradigm shift for the adjuvant treatment, which is not happened in the past 20 years before, but it's happened in this year. So chemotherapy still be the standard of care. In the patients with stage 2, stage 3 colon cancer with PIK-TCA mutation, you can add aspirin at the dose of 160 for 3 years after receiving adjuvant chemotherapy. And we can identify just only 1/3 of the patient that eligible for the aspirin. Or in the patients who have the MSI high or deficient MMR tumor, which is, we can identify just only 10% in stage 3. Adding immune checkpoint inhibitor can improve outcome. And moreover, you no need to test anything. You have just to tell our patient that you need to do more exercise so you can reduce the disease recurrence and you can improve the overall survival. So for my part, actually, I will focus only for the PIK-TCA, but I think the adjuvant data is very important as well. I will summary my talk with Alaska study is the first biomarker for the adjuvant treatment in colorectal cancer. And from the Alaska trial, in the patient who have stage 1 to 3 rectal cancer or stage 2 to 3 colon cancer who carry PIK-TCA mutations, adjuvant aspirin for 3 years can reduce the colorectal cancer recurrence. Thank you.
Thank you very much. Thank you very much, Professor Kitiya. Any questions from the floor? Can I ask?
Very nice lecture. Actually, many years ago, we heard about the probable aspirin may even prevent colon cancer. I think that's a long time ago. And I'm not sure whether or not this effect. When I studied my PhD in London, we study on the thrombosis and cancer. And we found that even colon cancer, they produce a lot of tissue factor that might affect that kind of fibrin net or whatever that can hide the cancer from destroy of the immune system, right? So I'm not sure whether or not because aspirin as a surgeon is like a toxic to, when we do surgery, we afraid a lot if patient get the aspirin. And as we know that colon cancer mainly occur in old age patient, and probably over 30% of them already got aspirin. So I'm not sure whether or not only aspirin, but also the other anticoagulant, like a low molecular weight, that might be easier controlled in terms of, surgeon idea, might affect this cancer as well. So how about in your idea? Are there any study compare the aspirin with the other anticoagulant?
I think we are for the implication for the using aspirin because it's quite safe. We have to wait for the bleeding list and the benefit for getting for using the aspirin. Low molecular weight heparin have more side effect about the bleeding. I think it's outweighed for using as a prevention of the treatment, but you can also use as a treatment, not for the preventions. Aspirin is quite safe, that, and I mentioned in the data that the bleeding complication is quite low. So for now, we recommend only aspirin, not for the low molecular weight heparin. For the cancer prevention, as I mentioned in the earlier slide, they can prevent the adenoma. That is why adenoma is the situation happened before turning into the cancer. That is why the aspirin can prevent for the cancer colorectal cancer development. So far, in my point of view, only aspirin is enough.
Thank you very much, Anna. Now, I think because it's very quick for NCCN guideline to introduce the aspirin to the recommendation. And now we start to have our patient print out the NCCN guideline and come to us. Do we need to receive the aspirin? How about the memorial sloan? Do you start to use it?
Yeah, I mean, it is brand new. So the issue will be tumor profiling for all patients and getting a quick turnaround to start it. So I think the data is pretty clear. Yeah, I think it has to be done.
I think for now, I test some of my patients because we can test for the PIK-TCA mutation in Silat Hospital with the in-house testing. But the cost of the testing, we cannot test for the PIK-TCA only. We have like a small panel for the colorectal cancer, and it costs around $500 a case, which is more than a cost of the aspirin for the whole 3 years. So we have to test for all of the colon cancer, stage 3 colon cancer, to identify 1/3 of the patient who might benefit. But I think our population have a lower PIK-TCA mutation. We have to think about the cost effectiveness, analyze cost effectiveness as well. But anyway, there is the newest data that shows benefit in the randomized study. So you can offer the patients to test it. And if you can identify, you can offer for the aspirin.
Okay. Thank you much, Professor Kitiya. We will gonna move to the next topic. For the radiation is a one main treatment for the rectal cancer for a long time that we all know. At Sirat Hospital, we back and forth for a while. We start with like a standard long course chemoradiation. And when the data of Lapido came out, we start to change to the short course and keep the consolidation chemotherapy. And after that, we got some weird things like when we do surgery, it's very difficult to perform the surgery. And we come back to like a standard long course again. Therefore, today we have our radiation oncologist to give a talk about a paradigm shift for the radiation in rectal cancer. Please welcome Associate Professor Chanchila Phetsuk-Siri. Thank you very much.
So good morning, everyone, and thank you very much for the organizing committee for inviting me here today, especially for Dr.